this ASD or ADHD features, whatever is the child is showing, is because of the environment that the child is in, or the family structure that that he or she is. So if the family is like 2 people or 3 people only, and the child is left alone with screen time, we all know all this thing, so nothing needs to be iterated. But because this plays a major role in finding out that the symptoms, the root cause of the symptoms. Hence, we should be having the proper demographic, within the demographic data. Apart from all those things, we should include this family constellation. Second is proper medical history. If there was mostly we find, we find that clear-cut case of ASD or ADHD does not, has no significant medical history as such. Whereas we, if we take proper case history, children who we think like are normal, looks normal when they come to us, 4-year, 8-year, 10-year, when they come to us, it looks normal, but maybe he was having a significant prenatal or postnatal case history. So just because the child is right now fine, I should not be ignoring the cases, his or her medical history before. So we should take proper medical history. Then again, as I would like to stress this developmental history. So apart from sensory issues, we should have the motor milestones. Like, yeah, now the child is walking 6 years, and the child is, the child is running, the child is taking off his clothes, the child is fine motor, gross motor, everything is fine. But how was it when was the developmental milestones on time? So that needs to be seen. Fourth is communication history. So we often tend to, or even parents say he doesn't say, but does the parent let him to say, or does he have enough opportunity to speak? So how is the communication at home? If parents are always busy or parents are with phone, the child often gets to ends up with the gadget, or ends up with most of the time it's with gadget only. For eating also, the parents will give nowadays will give this gadget to have him, to console him and have him proper feeding, easy feeding. So communication history of the family, not only of the child, of the family, how do they communicate in family, and how do the child is the child's need fulfilled immediately without even the child having to say? How is it? So proper communication history. Then behavioral history. So he has temper tantrum, he throws things. So these are all parents will say. So we it would be good, it would be proper if we ask the parent, like, how often does he get angry and why does he get angry? Do you know? So it's ABC. So but what are the antecedents for his behavioral problem? So if we have that, if when first time the parent comes, so it's not, they would not know, but then we can ask them to have a thought on it, and maybe next time they can come up to us, so that that's why we say that the first instant itself we can't say that we should not be saying, and that's we should not be diagnosing or labeling the child totally. And that's why we have this provisional diagnosis. Provisional diagnosis is for the time being. So for the time being, you feel like it's ADHD, but what about in 2-3 settings? And moreover, DSM-5 properly states that be it ADHD, be it ASD, at least in 3 settings we should be observing the child, in 3 or more settings, or with persons. So if at first instant you felt like it's ADHD, it's fine, but then watch him out for the 3 instances, and by that time ask the parent also to have the behavioral history, like the antecedents, and what did the parents do. So if the parents had rewarded him, rewarded or reinforced his behavior, undesirable behavior, then he'll again have that. So the consequences that the parent would if the child would be having to, that might again aggravate his behavioral problem. So his behavioral history improper. Okay. So the 6th thing is the pre-linguistic skills. Pre-linguistic skills, I mean, I just can't emphasize more about the importance of pre-linguistic skills in in children. I mean, before even the child having having a language, I mean, yeah, pre-linguistic skills develop along with subsequent to language, but then even before having proper language, children achieve many skills. So it's like, pre-reading skill, pre-writing skills. Similarly, pre-linguistic skills plays a very important role. So eye contact, I'm not stressing on eye contact, because eye contact at times, because the screen time, nowadays the screen time has taken too much of our eye contact. And earlier eye contact actually was not proper. If you recall, like, even we were being taught that we should not have eye contact with seniors or elders. So eye contact has had cultural notion, or had cultural values earlier. Nowadays we do make eye contact, but then yet it again depends on the child's age and interest. So depending on child's age and interest, eye contact is there. So yeah, we should have that, but I'm not emphasizing that on more, because that's the first one which we see. So I would say other pre-linguistic skills, that's imitation, object permanence. If object permanence is, you might be knowing that the child that say a object is present, and if it's just removed, so will the child go to find out? So if the child is not going to find out, then his cognition is actually impaired. So we just can't say that because or you may say that he is so hyperactive that he is not even attending to the object which has gone. But what about if I give an object of his or her interest? Then he should be going to find it out, isn't it? So pre-linguistic skills have actually a lot of cognitive component. These are also cognitive component. So attention, we have this scale of level 1 to 5, wherein like level 1 would be like pays attention to own work only, so which is like achieved by 1 year. So level 2 is like 1 to 2 year, level 3 is 3 to 4 year, level 5 is like so level 5 is like 5 to 6 years. So we have the child's age and all those things, and we should see like what is his attention level. So in case of if a child is hyperactive, his attention should not be less, isn't it? But yes, if he's ADD, so his attention would be less. So then turn taking. So if we can have turn taking, and see like if the child takes turn. It could be verbal if the child is verbal, or it could be non-verbal if the child is non-verbal, and see like if he understands properly, if he does it properly. Then we can have play skills. Through play skills also highlights a lot about the child's cognition. So there are 5-6 levels of play skills. So initially 0 to 6 months, it's exploratory play, when the child will just have the toy bang or shake or throw. So this play skills actually it's very important, because it also reflects the child's cognition. And as cognition, again, we all know that cognition plays a role in language development, because cognition and language are interrelated. So yeah, so the 0 to 6 months is exploratory play. 6 to 9 months would be relational play, where the child will take 2 things and compare or relate to each other, all those things. By 1 year, the child develops a pretend play. So he will take maybe a pencil and try to brush. So use the things on himself or herself. So self pretend play. And so if he does that, so we can find if he's at that level, so maybe the child's language cognition is almost 1 year. Around 1.5 years, the child would use the toys on the use those things on the toy. So maybe put the doll to sleep, make the doll to eat, or bath the doll and all those things. So simple pretend play. Then by 2 years, the child will have role play. So maybe teacher, doctor, teacher, student, doctor, patient, and or mother, mother, father, mother, child, and all those things. So role play. So this all actually, if we do, since as SLP we are not authorized or we don't own tests for cognitive this thing, but this test will give us will indicate us the cognitive level of the child. So in that way we can rule out or have an indication to our diagnosis. Moving to next slide. So then proper assessment. So if the child is hearing impaired, so we would do the non-verbal language assessment, FCS, and gestural communication scale. So if it's if the child is hearing, so we'll do this 3D LAT which is till 3 years, reels which is till 6 years. Okay, so I just come up with a new scale language test. This is ACSLS, that is Assessment Checklist for Speech and Language Skills, which is still 8 years. Then Manipal has come out with a language test called Assessment of Language Disorder, Manipal Manual, which is still 10 years. And LPT is for, there's no age, but then it gives a profile of the language thing. So we can use this test for verbal language. So, and in case of, for speech, like if the language is fine, or even if the language is not fine, if the child's speech is not clear, so we can use the speech intelligibility scale and diadochokinetic rate to see how the motor musculatures are functioning or how able are the motor musculatures to speak. This is a proper assessment. So moving on to, I would really like if someone, has any question or if any doubt, or if they don't agree with me till this point, I would like someone to, maybe I'll give 1 minute to have someone open up, or let's have a discussion. If you can add also, you can have feedback, feedback or or opinion, anything.
Mitali, I just want a clarification. Now we have the extended reels. The extended reels are still 6 years or 7 years. I think it's still 7 years.
I may be wrong. I'm not sure actually. I don't know. I can't recall.
6 years only. It's not in 7 years.
It's 6 years, is it?
Yeah.
Okay.
Okay. So let's move on to case scenario. So please, anyone has to say something, please, you can just unmute yourself and come up. So I have taken few cases, so to have a proper understanding. So this is a 12-year. There was a 12-year-old child who was wheelchair bound, and she was having lot of dyskinesia, actually, a lot of movements, like she would have spasms, and then her hand would go somewhere and her legs would go somewhere, and she was not controllable. She would fall down from the wheelchair also, and her tongue was totally like outside like this, and all these things was not like, she was not like this before. She had contacted with, she was afflicted by Japanese encephalitis at 9 years of age, and then she lost her motor abilities and lost her speech language control, lost cognition, lost everything actually. So in that case, I would put this question to the audience, like diagnostic formulation, how would you diagnose actually? What would help you to come to the diagnosis for this case? So what would you include for diagnosis? Yeah, we'll have case history, proper case history. We'll have the pre-linguistic, not the pre-linguistic, because she was having all those things. So we'll have clinical observation of the child's oromotor thing, and if OPMEs are fine or not, if she's able to eat properly or not, and because her cognition was pretty has pretty fallen down, so we would do 3D LAT on her, and some would prefer to do WAB on her, but I would not prefer her, not that I would not, but I think WAB would not be a right thing, because WAB is for adult, and actually the book that I mentioned, even that and AAMR, that is American Association for Mental Retardation, even that states that that mental retardation are cases which are manifested within the developmental period. So within the the developmental period is still 12. Again, we may have variation on that opinion. Some may say 12, some may say 15. So whatever the child is before 12 or 15. So her problem was manifested before the within the developmental stage, and then again, this is some would say that she had lost language. Yes, but then she had not only lost language, she had lost all her ability. Also, Piaget's stages of cognitive development says that the last stage, that is the formal stage, is still 12 years. Okay, so when the cognitive developmental stage has stopped at certain point, so yes, it makes sense to say that the child is intellectually disabled rather than childhood aphasia. Moreover, if you go through the new terminologies, new books actually, from 2002 onwards, childhood aphasia has been an obsolete term, and it's pretty controversial. It's a controversial thing. So instead of WAP, I would go for 3D LAT, and it's logical actually 3D LAT than WAP, because the child's cognitive development has stopped at certain point. Okay, sorry.
I just want to ask you something, like, but this is an acquired case, right? So acquired case, can we keep it as 12 years of developmental period? We cannot, can we, like, because this is an acquired, right? If it would have been a developmental,
it is acquired, but then see, that's what I'm saying, no? Like it is acquired, but it's within the developmental period. So anything AAMR, the definition of mental retardation is when it is manifested within the developmental period. So development period is still 12 years, we can say, and this child had Japanese encephalitis at 9 years. So the cognitive development had stopped actually, till 9 years. So she was in what stage of in Piaget's stages of cognitive development? What stage is she in now? Concrete operational stage. Yeah.
Correct.
So that's what, like in aphasia, when we say aphasia, yeah, although cognition and language plays a role, but then the definition of aphasia is loss of language, and cognition is not mentioned there, isn't it?
But in aphasia, they might have cognitive issue along with language.
Yes,
they might have.
True.
We can.
Yeah. No doubt about that. They might have, but then if you go for the proper definition, it does say that it's language. Aphasia is loss of language. Nowhere, or I don't know. Maybe there are no source. I don't think any source mentions that loss of cognitive this thing. Although we know that there is loss of cognition also.
So they always says that it might have associated issues of cognition. So in that way, if we take this child as aphasia, case of aphasia, so in that way also, like with aphasia, the child might have some associated cognitive issue. Can that be done? Like, I'm asking.
That's what I'm saying. There will be too many variations actually. So what I would say, as per my view, the cognitive development has stopped only. at least in aphasia, that's adult cases. So the cognitive development would have been there. Till 15 years, the cognitive development was going on. In this case, the cognitive development could not happen. It stopped. After happening, loss is different thing, and not happening is different thing. That's what I meant.
Okay.
Did you get my point? Am I clear? Like, it didn't happen. Like the child couldn't go to the next stage.
Yes, correct. Understood.
Her cognition, from that point of view, I'm saying that this is not aphasia, but this is a case of cognitive impairment, because the child could not complete the stages. After having lost is a different issues.
Okay, thank you so much. This was actually a big time. We always have a confusion, like what to be given, like before 12 years. So that's like, thank you so much.
My pleasure. So the diagnosis is delayed speech and language with intellectual disability. Although we are not we are not authorized, we can always put cognitive impairment, and in bracket maybe ID or query. So case scenario 2. A 4-year-old understands, his understanding is at par with normal, but then he doesn't speak at age appropriate level. He had no significant medical history, motor milestones were on time, has age appropriate linguistic skills, but he doesn't socialize. Okay, so here the moment we see doesn't socialize, so it comes to our mind maybe he was he has autistic spectrum disorder or something. So that we need to observe him in clinic, like is he having any stereotypical movements, because as ASD would have delayed speech and language, improper socialization, and then stereotypical movements. We should always have that thing in mind. Okay, it's in certain cases, some stereotypical movements could be just obsession or a habit actually. So we need to even be a little clear of if it's a really an obsession, or if it's just a habit of to do some certain things, or he just coping mechanism is a certain kind of coping mechanism. So we need to have that in mind. So in diagnostic formulation will be clinical observation, proper clinical observation, and then reels initially, I would say, because even if we go for CARS actually doesn't help us in planning the therapy program. So for planning the therapy program, we at least need to know the receptive and expressive, like how does he express. Verbal, if it's verbal, we can find it in reels, but if it's non-verbal, at least we can find out he is not non-verbal or something like that. So diagnostic formulation clinical observation is must in this case to rule out that this child is not that the child is not or doesn't fall in autistic spectrum disorder. So his diagnosis, because there was no significant history or something like that, so we come into a conclusion that this could be specific language impairment. So here, again, the clinician variability would be there. So some would say spoken language disorder because the child doesn't speak. He understands, but he doesn't speak. So then again, the thing is like, does it write or write or draw as per a 4-year-old? A 4-year-old would maybe make a square or make a sleeping line, standing line, or so. Does it do all those things? So if we say of spoken language disorder, so if he does that, then I would surely go for spoken language disorder. But then if he doesn't do, if his writing skills or is not as is not there as at par with 4-year-old, then I would go for specific language impairment, because language is the foundation. Verbal language is the foundation for written language. I mean, we started to read or write only after we started to speak and understand through hearing. So that's why I would go for specific language impairment in this case. If his reading or his writing and reading is not at par with 4 years. So any feedback on that? So anyone may have seen some, many would have seen a case like that. So wait for 1 minute. 30 seconds maybe. No, I think I'm taking too much time. So case scenario 3, moving on to case scenario 3. A 3-year-old follows commands, understands stories, but does not speak at par. No significant medical history, motor milestones were on time, has age-appropriate linguistic skills, except verbal imitation. I mean, his linguistic skills were all fine, except he would not imitate verbally. So if his he would do all non-verbal imitation. He would shake his hand. He would have all the body movements, but there are no verbal imitation. So my diagnostic formulation would be like, again, clinical observation is must to see if this speech linguistic skills are, how his speech linguistic skills, and that's how I come to conclusion that his verbal imitation is not fine. So clinical observation and raise. So then, I would, it would, have me thinking like, does he have apraxic, apraxia? Like, is he a childhood apraxia case? So in that case, if on clinical observation, I find that he actually has this apraxia component on him, then maybe I would go for apraxia test for children. And I actually don't recall, so I would have anyone to tell me, like, if what is the what test could we give? I mean, I would rather go for repetition of vowels and schwa vowels and syllables and all those things. I would go for that. So that will include in my diagnostic in my clinical observation, I would include that to come to a diagnosis of childhood apraxia of speech. But then I think 3 years is too early. So I would have someone to give a opinion on that. Like, what do you think it is? So maybe we'll have that as provisional diagnosis, and maybe observe him for 2 to 3 sessions. If he's shy enough, is it because like he doesn't imitate because he's shy enough, or actually he cannot? He has limitation in verbal imitation. So then we can come to conclusion for diagnosis as childhood apraxia after observing him in 2 to 3 settings. Okay, moving on to case scenario 4. So this is a 16-year child who is verbal, refuses to go to school, is average in academics, talks a lot actually, in fact, he would not wait for others to take turn. He's like restless, and he's obsessed with certain characters, especially like Korean characters and some BTS. BTS is a group or band of songs. So, and he often has some scare or some parents say like he is he's hallucinating, and nowadays like he would close the door, and the parents are actually scared like what does he do or something, and he often asks like that he would marry a Korean girl and all those things. So often and he actually irritates his parents asking small things repeatedly. So although he looks very normal, then on interviewing with him, I found that this child's cognition is actually much, is not at par with his age. So I asked few questions, and I picked up this assessment of language disorder of Manipal manual, and found that his receptive and expressive language is also falls like almost 10 years, almost. So then he actually, I came to when I asked the parents, like, was it diagnosed? In my mind, he would have been an intellectual disability instead of ASD. The parent was saying like he has autistic, he has obsession with certain things. He doesn't like to socialize. But then on asking, I found out that the child actually likes to socialize. In fact, on talking to the parents, for initially they say that the child doesn't like to socialize, but when they were talking to me, then they came up with saying that he likes to go to this uncle and this place and that place, but he doesn't like few places, and whoever he likes, he would ask to go to their place again and again, and whichever he doesn't like, he would not go. So that interest, that thing is in fact in normal people like us also. So in that case, I would not say that he is not socializing. And then his hesitation to go to academics was because his parent had transferable job, And so when he goes to new school, obviously, and then at this age, I mean at this age, he's 16 years, but he's going to class 9, so his academic is not that good. So this age it becomes like, in later stages of in later school transfer, children actually face difficulty in gelling up with other children when it's like late school transfer. So that's why, because he was not familiar with those people, that's why he was refusing to go to school. It's not that he doesn't like socialization. He's unlike his dislike for socialization is because of certain things, and that's pretty much okay, and that's we cannot, I mean, it's not certain to do with something like autistic spectrum disorder. So the diagnosis, I conclude it as a ISL with intellectual disability. On asking the parent, like, was he interviewed, or did he had tested before, and it was found that he already actually owns a disability certificate, which was ISL with ID. I was so thankful that I did not ask for I mean, I was so happy that I did not go for cards and wasted my time on that. So we should be really careful to avoid quickly put a diagnosis of ASD. Most of the time, this cognitive impairment or children with mental retardation do have features of ADHD or ASD. You can find out on the book, as I mentioned, manual on communication skills of for mental retardation. So many symptoms are there of in mental retardation. Many ASD and ADHD symptoms are there. Moving on to case scenario 5. So this is an 8 years who is hyperactive, and he's inattentive. He parents say like he doesn't attend to any questions on asking. He just keep on doing his things, talks relentlessly, and he can actually, when he came to my room, he was like so normal, because like he was picking up pen, and as an 8-year-old he was like writing names of songs. Actually, initially I thought he was writing movies name or movie name, or he was writing rhymes. But later I found out like these were all songs which he has heard, and he was writing this things in very nicely. There was some Jibon Bath or something like that. He was writing so difficult things on papers. He was like taking up papers and writing all those things. It looked as if he was so studious and so so he's studious. Actually, it looked like his reading and writing skills were at par with an 8-year. But he was like very violent, and he was restless. He would just throw things, and he would just tear things off. So all these violent behaviors were there. His medical history was not significant. Motor milestones were also on time. So in this case, because his attention was poor, so the attention scale was used, and because he was writing all those things, so to rule out that there is no cognitive impairment, we as an in our course, we all had our postings in psychology department. So from there we know like what is the gestural figure diagram test. We have that a circle and a circle for 3 years and all those things. So had him do the GFD. And I found like, yes, he could not do the copy the item for 8 years, and because he was speaking, he was verbal. So reels he would automatically pass, and he had passed actually. So did this test made of from ISHA, ACS, LS. And it was found like felt like although he was speaking so much, although he was writing so many things, but there are a deficit of cognitive impairment, because his attention level was poor, and he actually would not understand. He would not repeat the. He would not say the question's answer. You talk to him, he will say something else. He doesn't attend to the question, and he most of the time he doesn't understand also the question to even answer. He says things of his interest. So yeah, you would see these things in case of what to say, autism spectrum disorder or ADHD, where they don't take turns, they don't wait for turns for them to speak, or you would even feel like he's ASD, because like he was obsessed with certain words and certain songs, and he was repeatedly going on telling them. So at times it was too confusing for me also that he would be ASD or ADHD. But finally, it came to it was understood that his cognitive is less, and because he doesn't understand like what to do, how to do, he was violent or he was restless. So the diagnosis was we concluded the diagnosis as DSL with cognitive impairment. And now when the child went for actually IQ in IQ test to GMCH, it was found that he had borderline cognitive impairment. I hope I'm not taking much time. This is the last slide, I guess. So I'll quickly run to this. So the case scenario 6, a 12-year-old is poor in reading and writing. He doesn't listen to parents, keep asking and mentioning what cycle day in and day out. So he has difficult to manage, it has become difficult to manage him day by day, because he would not listen to his mother and his father also. In fact, he was becoming rebellious. So this all actually, these symptoms are becoming rebellious and difficult to manage day by day is actually normal in almost all adolescents, during all adolescence periods. So kept aside those things, and I interviewed the child, like why does he ask, why do you ask for cycle, and whatever the problems, whatever the parent said, like he asked for cycle and biscuit all the time. He would not eat outside. So when I asked those questions, even he was not able to reply them properly. He would just say, okay, he eats, so I eat, or my father doesn't give me this. So on conversing with him, I found he actually doesn't understand the question, or he cannot figure out what to say. He can process how to answer that. So the questions, why questions, how questions, he was not able to say properly. Although he would speak a lot, but then questions ka answer he was not able to formulate. So I also did. GFT was also implemented on him, and it was found he could not. We cannot say like by doing GFT he is cognitive impairment, but then this interviewing the child, asking why questions, telling him a story and asking him questions, why did this happen, why did, although the king was doing well to the what to say, his public, why did public became rebellious? So telling him story and asking him questions, but through discourse, it was found that he doesn't understand the questions properly, doesn't understand the complex sentences, embedded sentences properly. So a conclusion, along with GFD and this thing and this interviewing, it was concluded that he has cognitive impairment. So the diagnosis was made inadequate speech and language with intellectual disability. That was this was what I wanted to share, and thank you so much for listening to me patiently. And if you have any, I would surely like to hear from you, like if I was, if some feedback, actually if something else could have been done, or or you can share your your case also, like which you are having maybe, and so if maybe you if you have a case wherein like you feel like now that he is cognitive impairment, till now he was you had been thinking of autism, but then he is cognitive impairment. If you have certain cases, so you can you can share that. But otherwise, yes, autistic spectrum disorder cases are on rise, but then it's very it's very obvious when we see a autistic spectrum disorder child and a cognitive impairment child. Autistic spectrum disorder children have very bizarre and very stereotypical movements. They are just not there around, they are just somewhere else. So whereas in mental retardation cases, you would see like they have the socialize, they like socializing, they do not have that much of stereotypical behavior. So this clear cut thing, this we need to be clear about this what to say, this diagnosis, this differential diagnosis. Thank you so much for listening. I would like to hear from you now. I have been speaking a lot.
Thank you, MITALI, for a very detailed and exhaustive talk. Although we all have, most of us have done a master's, but sometimes making a diagnosis is not a cakewalk, and we tend to be in a fix. So thank you so very much for clearing so many confusions that we have had. And I really wish, I'll say this again, I really wish the students were here to listen to this talk today. Thank you so very much. And I hand over the session to Pritismita to give the vote of thanks.
I would like to ask if there are any questions. I think there's a few questions in the chat. One is, what is ACLS?
ACLS is an assessment checklist for speech and language screening. It was developed by ISHA, and it's still 8 years. So you have receptive, not receptive, they have not mentioned as receptive, they have mentioned as comprehensive, comprehension skills and expression skill.
Okay.
Yeah.
I really wish today's talk all the students and all other juniors would have heard it, because for us only it was so much of brushing up, and also so many things we are coming up with. Actually, it's such a nice topic. Thank you so much, MITALI, for sharing with us. Okay, again, there is one more, I think it's Pragya ma'am, she has written, delay deficit in cognitive skills or intelligence itself may have underlying causes, sensory processing difficulties, partial fluctuating deficits in hearing or visions, etc. Are we correct to label ID and cognitive deficits as a diagnosis, or do we need to dig deeper?
Are we, sorry, I didn't get, are we?
Correct to label ID and cognitive deficits as a diagnosis, or do we need to dig deeper?
That's what I'm saying. So we are not authorized to say, we are not authorized person to say ID. So that's why I'm saying cognitive impairment in bracket ID and then query. So
yeah, that's what she's asked about multidisciplinary approach. So
yeah, we should be having that, but then again, ideal world is hardly found, right? Ideal setting is hardly found. So we, I mean, because we when we write DSL with ASD, so DSL with cerebral palsy, DSL with delayed motor development. So we can surely write DSL with cognitive deficits. We have 3D LAT, and we know that the prelinguistic skills are I would say indicate the cognitive status. So I don't think so there is anything wrong in writing DSL with cognitive impairment when we can write DSL with ASD, DSL with DMD, and all those things.
Zaliba, my question is not about are we authorized to diagnose or not. My question is, like, especially the cases that you've mentioned, the 8 years and 12 years. Diagnosis is a different issue, but when we are seeing intellectual deficit or cognitive deficit in 8 years and 12 years, do we also need to look deeper about the underlying cause behind the intellectual disability or cognitive deficit, and maybe do we need to address that also at that point of time? That was my question. Not really are we authorized.
No, I'm not saying, I'm not really that I'm, even I'm saying that what is wrong in writing the, I mean, I'm not saying that you should not dig deeper, but then what caused, I mean, in this case, 12-year, the one who had Japanese encephalitis, the cause is right there. So any mental retardation which is manifested within developmental period are labeled as developmental deficits, which are manifested cognitive deficits. I mean, mental retardation are the cases where not only the cognitive deficits, but also adaptive behavior and the same problem solving skills are all affected. So yes, dig deeper. Interviewing, that's what, no, I mean, while doing the interview, that's why you dig deeper. Clinical observation, you are digging deeper. That's what it's clinical to clinician, how much time one is giving, what questions, it's very subjective. So there's no standardization. That's what I'm saying. There's no standardization. It's so much of variability, and clinician to clinician, time again. So one clinician who's very much popular will have more and more cases. So she or he may not be able to give that much time, because time is after all money. But for me, time is no money. Working government setup, so I give lots of time, so I dig deeper. So again, many factors matter. So yes, you should, I mean, we should dig deeper, and we should always refer, if we have psychologists at your doorstep, you always refer to them. So not, I mean, I am also stressing that this, it's, if you have dig deeper, it's nothing wrong, and if you have actually found, yes, the child is not understanding. So cognitive, again, do you mean that CT scan and MRI? No. So in certain cases, in this 12, one who had Japanese encephalitis, obviously her CT scan would reveal that lesion in the brain, when brain's affected. But the ones who was very normal, Dr. Rib also did not advise him to go for CT or MRI. So you may not find any brain lesion. So
no, I didn't mean CT, MRI. I just meant maybe occupation therapists and psychologists. And
yes, sure. We should. In fact, I also did, but then at times, if it's not available, if it's or the person or the parents are not able to access, then we can have discourse like conversation. Through conversation we can find, like, why questions, how questions, and problem solving skill, problem solving methods, reasoning, judgment. Through all those things, we can come to a conclusion. But then again, as I said, there's no such standard as such, no standard, and then it varies from. We have clinician. That's why I picked up this topic, because it's too much variability is there in diagnosis. Too much variability.
I think ISHA is going to come up with some uniform protocols for diagnosis within another 1-2 months. That's what I have heard. So they have been making some uniform diagnosis, like how we used to write ISL, DSL as SLD. So like somebody write ISL and DSL, some people write SLD. I think that's been confusing throughout. So they're coming up with few uniform diagnosis maybe in another 1 month or so. So I think that would help us again, like for an SLP, how to do, and then whom to refer for what, and then how we should go along with their from the co-disciplinaries, this one, diagnosis. So maybe that
even I hope it would be, I hope that it would be good and nice. I hope that they also remove the spoken language disorder, which I feel is very absurd, because whom will I say spoken language disorder? Yes, in a child who is maybe childhood apraxia cases, I can say spoken language disorder whose writing is fine. Only on them I would say spoken language disorder. I would not say spoken language disorder in a child who is who understands everything. But that's what. So
I think SLD is used for, not for who understands everything. SLD is used for not for that is who understands everything and everything is fine, like sensory impairment. That those are the SLIs, I think. But then SLD was coined for the term instead of ISL and DSLs, which we used to write, like delayed spoken language and inadequate speech and language. For that, they had given SLD, like, because since when we were in internship in ISHA, Since that time, they suddenly said like, you don't write ISL and DSL, start writing, instead of ISL and DSL, you should write SLD. But for SLI, it's not SLD. We are not supposed to write SLI ke liye SLD. But that's again
Right.
becoming a confusing things. And I think that's what again ISHA is developing within a month or so, like what we should actually use. It should be ISL, DSL or SLD. So it's
So
still like
ISL is actually after the developmental period. Inadequate speech and language is after the developmental
Like
period.
after
That's what
12
we
years.
learned. And delayed speech and language is during the developmental period.
Yes.
So actually, this is much better, much
Yeah,
clear
that's
diagnosis.
better. That what we used to do before our internship, like in ISH, and suddenly they say us don't use this. Start writing SLD instead of ISL or DSL. So
Then
that's
I would
when we
ask
started
Aish actually, then if it's a spoken language disorder, is this written language fine? Is this verbal language? I mean, is this gestural language fine? What about the other parts of language, modality of language? Instead of, we should not be going for the modality of language. If it's spoken language, fine. What about reading or writing?
No, I think we are more of looking into the spoken part, right? Because it's the speech and verbal part. So maybe that's why it's the spoken language. We're not looking into the other part, right? We're not looking into the
Spoken
augmentative
language is fundamental. Pritishmita, spoken language is the fundamental for reading and writing. When the fundament is not proper, how can we have the higher skills better? Written language will also be improper to him.
So, so you mean to say like we should write verbal language disorder maybe instead of spoken language?
Yeah.
Be more better.
Yeah, maybe Pritishmita, since you were new or something, please, you can convey. I have no this thing nowadays to improve my field. I'm tired. I have become old and all those things. So you can convey this to Aish, because you are pretty novice. I mean, pretty connected. And I am like disconnected from what.
No, that's what,
So-
like that day we were having a discussion. That's what was the thing going on. So they were all like, so that's what they're coming up with something maybe uniform protocol. So that will be good for all of us. So I hope there's no other question. Is there any other questions? If anybody has any other questions, can ask. The juniors, we don't have any questions. All right then. Okay, thank you, Mitali. This was such an enlightening topic today. We actually had a very nice brush-ups and very lot of things we again had to think about. Okay, so thank you so much for this talk. I would like to thank all the participants, our technical team, Mridul, Nirmal, and Dhruva for helping us with all YouTube, Insta, and Facebook publicity and everything. Thank you all the AC members for making this meeting happen. Thank you, Mansiba, for coordinating.